This program is brought to you by Emory University.
Good morning, everyone. Welcome to the first cardiovascular grand rounds of the new calendar year. It's good to see everyone here. We're going to start off this year with Dr. Marv Konstam, who's visiting us here from Tufts Medical Center, where he is the chief physician. Let me get that right title right. The chief physician executive of the Cardiovascular Center. He's served many administrative roles there, including a chief of cardiology through 2007. Marv has a background in both cardiology and radiology, and has really been one of the major players in the heart failure world for many years now, and is past president of the Heart Failure Society, and has served as on many steering committees, involved in most of the major clinical trials, and has just been a spectacular contributor to the field of heart failure and heart failure therapy. I was particularly impressed with actually an editorial he wrote, I guess it was last year, in Circulation about remote monitoring, and we get enthralled with technology, and I thought one of the interesting things about that editorial was not only a great summary of the field of remote monitoring for heart failure, but the importance of integrating technology in the patient-centered care, and that technology can't replace patient-centered care and our knowledge of individual patients and strategies for patient care. As I said, he's been a major contributor through many aspects of heart failure, and he's going to talk to us today about cardio-renal syndrome and acute heart failure. Mark, welcome. Good to have you here.
Thanks so much. Thank you. Thanks for that fabulous introduction. I'm always impressed that somebody actually read something I wrote. That was awesome. And I just wanted to say first, I was hoping to see Javid Butler here. He's become a dear friend of mine through our mutual participation in the Heart Failure Network, which you guys are NHLBI Heart Failure Network, so anyway, I know that he's struggling with his dad, and we wish him well. I was telling Dr. Taylor that I really think how great it is to have this conference at 7:30 in the morning on Monday. It's the way to start the week off. I was a little worried about, would anybody actually be here? Would anybody come to pick me up at the hotel? And I was greeted by your Greek mafia, Andreas and Vicky, and I said, "Oh, great! The Greeks never sleep anyway, right? So it's just as well that you have a conference at 7:30. But it's really a delight to be here." One final note is that I'm pulling for the greatest Super Bowl in the history of football, the Falcons against the Patriots, and I hope that happens, and may the better team win. Okay, so we're going to talk about the heart and the kidney. This is a view from a country cardiologist who's learning about the kidney and the interrelationships between the heart and the kidney, particularly in the setting of acute heart failure. I have my disclosures down at the bottom, which I'll let you stare at for a moment, and we'll make sure that we clearly identify treatments that are investigational versus FDA approved. Okay, so brief introduction about the importance of heart failure. Dr. Taylor mentioned integrated care, and we really do have to think about new approaches to modeling care, because this is what's going to happen if we keep caring for patients exactly the way we do today. This is a wonderful report that Paul Heidenreich led on behalf of the American Heart Association, published in Circulation in 2011, that looks at the projected prevalence and economic impact of heart failure in the coming years. It's principally based on the aging of the population, this analysis is. Not much beyond that. But based on that, it's projected that over the next 20 years, there'd be a 25% increase in the prevalence of heart failure in the U.S. population. And if left to our own devices, treating patients exactly the way we do today, that would result in a 215% increase in direct costs for heart failure based on 2008 dollars. And so I will declare to you this is not going to happen. There is not going to be this kind of exponential growth in costs in heart failure. It just can't possibly happen. So something is going to change. We're going to change the way we care for patients, and the way we allocate resources and the way we approach it. One plug would be that I hope, and I'm going to personally work as hard as I can, I hope you will as well, that in that transition, we don't throw away the pearl that is academic medicine. I think academic medical centers, really are under siege, are going to be under siege in the New World Order, in the evolution of health policy in the U.S. Because it's kind of low-hanging fruit. So we have to work hard to make sure that we can retain the academic missions of research and teaching. Okay. We've done very well in heart failure, mostly chronic heart failure, and the patients that have been studied over the years are predominantly those with low ejection fraction. And in that construct, we've done actually extremely well if you look at the big picture. And this is a plot of, some of the benefit that we've achieved with implementing ACE inhibitors or ARBs, beta blockers, and aldosterone blockers over the years. The degree of reduction in mortality that is illustrated in clinical trials of these respective therapies. I think actually the aldosterone estimate of an additional 15% reduction in mortality is probably an underestimate. That number is based on Rawls, but it's probably higher, a greater reduction than that. And all of this, of course, is in the domain of neurohormonal antagonism. And it really speaks to the point that what we've done is we've identified treatments that actually make the heart better. They don't just whip the heart. In the early 1980s, the focus was let's find a newer inotropic agent that could whip the heart. All we had was digitalis, digoxin, and then if we found new inotropes, maybe we could improve patients with heart failure. Then the thought was vasodilators, but we really landed on neurohormonal antagonists as the therapies that worked, probably by accident, essentially, in those days. But we've hit a home run with that because those treatments actually make the heart better. How do I know what makes the heart better? The simplest thing to measure is how big is the left ventricle in patients with dilated ventricles and a low ejection fraction. And I'll point out this publication by Dan Kramer, a trainee at our place, really led by Jim Udelson, my colleague, where we looked at every study we could find in the literature where there was a measurement of change in remodeling parameters, including ventricular volumes and ejection fraction, for treatments for which we knew the impact of that treatment on survival based on one or more randomized controlled trials. So these dots each represent a study that looked at changes in ventricular volumes, and it's change from baseline in end-diastolic volume or in systolic volume on the x-axis, and the odds ratio of death based on independent randomized controlled trials for that particular treatment modality, drug or device. And so what you can see here is, although there's some scatter, there really is quite a strong interrelationship. That is, if a treatment shrinks the heart, if it reduces adverse pathologic myocardial hypertrophy, if it reduces ventricular volumes, it is very, very likely to reduce mortality. I think if you're thinking about surrogate endpoints or how do you predict that a drug is going to reduce mortality, that one measurement more than anything else in this population is what will predict it. And so we have drugs that make you better, that make the heart better, and that's why patients live longer. We could talk about what the mechanisms are. And the challenge is that we have not done the same thing in the setting of acute heart failure. In fact, in the setting of acute heart failure, we mostly give drugs that have a neutral to adverse effect on the heart, particularly inotropic agents, which clearly don't make the heart better. They whip the heart. And so the key is going to be figuring out how to improve the patient acutely which means hemodynamic improvement, clinical improvement, improvement in clinical endpoints in the acute setting, but at the same time give a drug that's not going to make the heart worse. And I tell the house staff and cardiology fellows, when we have a patient lying in the ICU on inotropic agents, we come on rounds in the morning and say that the challenge is figure out how to transition this patient from drugs that make you worse in the long term to drugs that make you better in the long term. The importance of hospitalization for acute heart failure is suggested in this slide that shows that if you're hospitalized for heart failure, it's a very bad marker, and that in fact in this analysis, 33% of patients hospitalized for heart failure were dead within 12 months. I think that's actually an underestimate based on a broader population-based analysis. So if hospitalization for heart failure is a marker of badness, now if we give drugs that make you worse, then that can even exaggerate the problem. But it certainly is a marker of bad things happening to patients. And where are we today in the therapy of acute heart failure? You know, we're nowhere near where we are in the setting of chronic heart failure, and conversely, nowhere near where we are in the setting of management of acute myocardial infarction, where we've done a great job of identifying treatments that actually reduce the injury to the myocardium and therefore improve survival. We don't have that in acute heart failure, and there are a variety of reasons why. I think it's an extremely challenging domain to investigate, but this is the state of affairs for acute heart failure. All the therapies that we have available for us, most of them anyway, are listed here. Levosimendan available in Europe but not in the United States. Nasiratide, conversely, in the United States but not in Europe. And this is the regulatory approval basis, unlike the bar that we set in chronic heart failure, and now we're trying to set in acute heart failure. In acute heart failure, the regulatory basis for these drugs has overwhelmingly been hemodynamic changes. In the case of nasiratide, was a 3-hour dyspnea endpoint. And when we look at outcome effects of these various therapies, it's pretty sobering that there's either no effect on, either there are no outcome data, or perhaps at best the effects are neutral. But in several situations, there's particularly in the case of the inotropic agents, there's concern of excess mortality associated with the use of these agents. This has been raised with nasiratide, probably not correct. I'll show you the study that showed that. But anyway, certainly we don't have therapies to this point that we know improve outcomes when we give those drugs in the acute setting, except, of course, if we can get the patients on ACE inhibitors, ARBs, beta blockers, and aldo blockers during that hospitalization. That's a really good thing. Okay, and I'll point out, and we're going to talk about heart-kidney interrelationships, and I'll point out that heart failure is not all about the heart. In fact, it's a systemic illness with contributions not only by the heart and the neurohormonal system, but also the vasculature is a critically important organ, if you will, in the genesis of both chronic and acute heart failure, and we won't say much about that this morning. But the kidney is also a critical contributor, and that's what we're going to explore for much of this discussion, is those interrelationships. And these three organ systems, the heart, the kidney, and the vasculature, sort of gang up to produce the syndromes of heart failure, because heart failure is not a single disease. You know, it really is an end result of these organs screwing up, but may manifest in one of a variety of different syndromes, as illustrated on the slide. Okay, now let's start talking about the kidney and what we've learned over the years. And I go back to this study. Amin Al-Ahmad was a cardiology fellow with us in the late 90s, early 2000s, and he did this analysis going back to the SOLVE study, and this is one of a number of analyses that were done at that time in the early 2000s that really clarified the strong relationship between kidney function and outcome in patients with heart failure. And so we went back here and showed, you know, of course, if you had really bad kidney function, you couldn't get into the SOLVE study. But if you had an estimated GFR less than 60, you had significantly worse survival probability than if you had more normal kidney function. More recently, this is a recent study by McAllister and his colleagues in demonstrating the impact, well, first of all, the prevalence of kidney impairment, of renal functional impairment in the setting of heart failure, and they divide up patients with preserved ejection fraction compared to reduced ejection fraction. It looks fairly similar. This is a histogram based on estimated GFR on the x-axis and percent prevalence on the y-axis. And what you'll see is that at least 50%, if not more than 50%, of the population of both those with preserved ejection fraction and reduced ejection fraction have reduced kidney function among those patients who have heart failure. And what's the impact based on this more recent analysis of reduced kidney function on outcomes, nicely displayed here. And interestingly, separating those patients with reduced and preserved ejection fraction, showing this very clear relationship in those with low ejection fraction, ischemic cardiomyopathy, dilated cardiomyopathy. That is, that as estimated GFR goes down, the hazard ratio for all-cause mortality goes up predictably. In heart failure with preserved ejection fraction, it's not as crystal clear and as pronounced, interestingly. In this funny shape to the curve, it actually looks like modest reduction in GFR is relatively protective compared to the highest level of GFR. I'm not sure that we understand that. And then when you get down here, you start to drift toward worst outcomes. So this is an interesting area to explore further. But certainly in this population, worse kidney function predicts worse outcome. Now, so, this is from a paper I wrote now in 2011, trying to look at the different ways in which we can explain this relationship between kidney function and outcome. And it's just a simple schematic that points out that the potential complexities. Heart failure may induce kidney function. Heart failure may induce kidney injury. It may directly impair kidney function. And of course, people with heart failure have increased survival, reduced survival. And this relationship between GFR and survival may be direct. It may be that worsening kidney function actually directly impacts on clinical outcomes and survival. Or it may be an epiphenomenon, if you will. That is, patients with the worst heart failure have the greatest kidney functional impairment and also have worse survival. Now, when you throw in treatment, it gets even more complex. And of course, it's possible that to the extent that worsening kidney function actually directly reduces survival, it's possible if we identify a treatment that improves kidney function, we can directly improve survival. And there's a lot of interest in that direction. There was interest several years back, for example, with adenosine receptor antagonists, which may protect the kidney, and then the thought would be that would maybe improve longer-term outcomes. The large clinical trial with that approach did not work out very well, but it is an intriguing possibility. But when you look at inhibition of the renin-angiotensin-aldosterone axis, you see that the direction of effects is really quite different. And then, in fact, here you have a class of treatments that clearly we know improve survival, and yet they actually, in the short term, worsen GFR, but they also, in the long term, can protect the kidney. So, in fact, when we interject treatment, we may, depending on the exact mechanism that we're working with, we may substantially impact upon the interaction between kidney function and survival. So a couple of slides and studies that sort of illustrate some of this. So we've done a series of analyses recently from the HEAL study. You may be familiar with this study, published a couple of years ago. It was a long-term study comparing 50 milligrams to 150 milligrams of losartan in a population of patients with heart failure and low ejection fraction. About 3,800 patients. Median follow-up actually was the most striking thing about the study, about 4.7-year median follow-up in the patients. So it's a pretty powerful database to explore. And so let me show you a couple of things that we've shown out of that database related to renal function. This is work of my colleague Mike Kiernan. And so the first point is, during ARB administration in the course of the study, what are the predictors of worsening kidney function? And the principal predictors were patient age, concomitant use of aldosterone blocker, and baseline serum creatinine. Also, we happen to have those patients who previously had manifest worsening kidney function during ACE inhibitor administration, and that, of course, as you might think, was a considerable predictor of worsening kidney function during ARB administration. So these are some of the predictors we identified. Now, importantly, and digging deeper into this and thinking about the renin-angiotensin system blockade, the results were very different whether we saw worsening kidney function early after implementation of therapy or later during implementation of therapy. Why? Because these therapies directly impact renal hemodynamics through effects on the efferent renal arteriole, and so directly reduce GFR, but do not necessarily injure the kidney. In fact, we know this class of agents are renally protective. So we separated out those patients in the HEAL study who had overall worsening kidney function, looking at the whole population or all of those events, comparing those to what the subsequent outcome impact was in those patients who had early worsening kidney function, that is within the first 4 months. And in fact, if we look at the entire population of patients with worsening kidney function, there clearly was a worse hazard ratio for the outcome effects. And the outcome that we were looking at was death or heart failure hospitalization. But if we looked at those patients who had worsening kidney function during the first 4 months, that meant nothing in terms of worsening survival. So when we start an ACE or an ARB, ACE inhibitor or ARB, if we see modest changes in kidney function in the early going, we should not stop therapy. In fact, that doesn't mean at all that we've done anything to make the patient worse or induce kidney injury. In fact, some of the the impact of worsening kidney function correlationally with survival may be driven by the fact that clinicians stop evidence-based therapies when they see worsening kidney function. And that very point is suggested in this slide, which is really a very nice analysis from the Rawls investigators published last year. And I'll just focus on this top panel. It's a complicated slide. But this makes the point. So this is, of course, spironolactone against placebo. And if you isolate the placebo group in the Rawls trial, and you look at the patients with worsening kidney function versus no worsening kidney function, you find that in the placebo group, worsening kidney function predicted significantly worse outcome in terms of all-cause mortality. But if you look at the spironolactone group, those patients randomized to spironolactone, there was absolutely no difference between those patients with worsening kidney function versus without worsening kidney function. So if you're on spironolactone and you start it and you see worsening kidney function, it does not portend an adverse outcome. And furthermore, if you just focus on these darker lines, the darker solid line and the darker dashed line, you see the impact of spironolactone versus placebo in those patients with worsening kidney function. So in those patients with worsening kidney function, there was a more dramatic effect on reducing mortality than in those patients in the lighter lines who did not have worsening kidney function. And it sort of really brings home this point of, number one, about how complex these interactions are, and you shouldn't assume anything. But secondly, I do believe that part of how patients do worse when they have worsening kidney function is the clinicians stop evidence-based therapies and feel forced to do it. So I just would sort of be cautious, be a little bit more thoughtful in how we approach it and consider the direct effects on renal hemodynamics of the drugs versus kidney injury and whether we're really doing the patient harm. Now, moving into the setting of acute heart failure, we've seen very much the same correlational observation with regard to the significance, the clinical significance of abnormal kidney function in predicting adverse outcomes. And this is from our study, the Everest study, which I'll come back to later, which is a randomized controlled trial of a vasopressin receptor antagonist in heart failure. But Mihai Georgiadi led this analysis that looked at baseline kidney function as a predictor of adverse outcome in patients with heart failure. The endpoint here is mortality or heart failure hospitalization. Creatinine on the left, BUN on the right. These sequential Kaplan-Meier curves represent cumulative event rates in patients with worsening and worsening baseline kidney function. And we found that both baseline BUN and baseline creatinine were independent predictors of adverse outcomes, very similar to what was found in the ADHERE database. But the ADHERE database findings was limited to in-hospital events. This looks at long-term events over a 9.9 month median follow-up. So somebody coming into the hospital, baseline BUN, baseline creatinine are both independent predictors of worse outcomes in those patients. In addition, I'm not showing you the data here, but in addition, we found that if kidney function worsens during hospitalization, during the course of treatment, which is usually focused on volume management, if kidney function worsens, that also portends a worse clinical outcome. So either baseline abnormality or worsening during treatment represents a suggestion of a worse outcome. Now, cardio-renal syndrome, what is it? Well, first of all, there are various types of cardio-renal syndromes that are described. The one I'm focusing on really is the one where the heart drives kidney impairment. So there are lots of different types of interactions we could talk about, but let's just focus in on how does heart failure impact on kidney function. And this is a ridiculously busy slide, and I apologize for that. We won't go through details. I'll refer you to this. This is the article on the cardio-renal syndrome that we wrote within Up to Date. And it suggests a variety of different mechanisms, but I'll just make 2 points. One is the one that you all learned in medical school, the so-called prerenal azotemia, and that means that if the kidney is inadequately perfused, kidney function can decline. So here's left heart function with reduction in cardiac output, secondary stimulation of neurohormonal systems, which together result either directly in kidney injury or directly in abnormal kidney function. And that's clearly one pathway, is if the kidney is not adequately perfused, it can show we can have worsening function. Remarkably less well recognized, but absolutely every bit as important, is the impact of right heart failure and elevation in central venous pressure and renal vein pressure in the driving of kidney impairment, renal impairment. And so as renal vein pressure goes up, there is an increase in there is a reduction in transrenal blood flow. There may be an induction in renal edema, and so that's a critically important mechanism as well. Not as well recognized. People don't talk about it. They don't think about it. I think we think all about, if we see a rise in serum creatinine in patients being treated with heart failure, we think about the Starling curve and the forward output effect. And we usually say, okay, we have to back off diuresis because we're impairing the Starling mechanism and impairing forward flow. But there's this other thing going on that's every bit as important. If central venous pressure is elevated, we're being challenged by elevation in renal vein pressure. And what's the evidence for that? Well, as you can tell, I'm really trying to stick with only the most recently published data, because this is a very smart group, and everything in the literature. Maybe I can hope to bring you something, hot off the press that you haven't gotten a chance to read about. This is an example of that. It was published in 1931, Okay, and I actually missed this particular issue of the Journal of Physiology in 1931. I'm sure Dr. Hurst would have remembered this one. But I actually spotted it in a more recent review and then went back and looked at this somehow, dug it out from the library, amazingly. But this was the finding of these investigators in 1931. They looked at a canine kidney and preparation, and what they did is they merely increased renal vein pressure in this preparation. And as they got to about 20 millimeters of mercury in renal vein pressure, they saw a plummeting of urine output to near zero, and it stayed there and miraculously returned to normal. In fact, this rebound diuretic effect that they saw when they abruptly reduced renal vein pressure back to a normal level. And that's all I'm going to show you. I mean, there are some recent studies to support this, but this is just a nice, beautiful, simple, elegant investigation that makes it crystal clear that renal vein pressure has an impact on kidney function. So it's something to keep in mind as we treat our patients. So I guess that the take home there is that if you have a patient who is volume overloaded, you have to figure out a way to normalize that volume overload. You got to do it. You either have to do it by continuing on at a more modest rate of diuresis, supporting them with agents that may support kidney function, perhaps, although we don't have great evidence for that. I'll show you a little bit of that. Or think about aquaresis or ultrafiltration, although we'll show you some data that makes us cautious about that as well. But you got to think about something to normalize intravascular and extravascular volume. Otherwise, in the long run, the patient's just going to bounce back into the hospital. So I want to introduce everybody to something you know already about, which is the NHLBI Heart Failure Network. Here are you guys down here, and here are us up here. And so this is actually a neat kind of community that gets to do clinical trials together, medium-sized clinical trials, 200 to 300 patients, usually phase 2 type studies, if you will, surrogate type endpoint analyses or symptomatic endpoints. And we're trudging along, and I think in this second round, we're going to, and I think both you and we joined it as regional coordinating centers in this second round that just started a year ago. I anticipate this is going to be highly productive. And let's look at some of the work that's gone on and is going on, because there seems to be an awful lot of attention being placed on this cardio-renal syndrome. So the first study is the DOSE study that was published in 2011 by Mike Felker. And what was done here in a factorial design in patients hospitalized with acute heart failure, patients were randomized to either high dose versus low dose furosemide, and simultaneously randomized either to continuous infusion or pulse therapy. And the endpoints were this global visual analog scale, and the short story is the whole thing was not statistically significant. There was no clear evidence of one mode of therapy versus the other mode of therapy being more effective. This is a display of that, and it's a complicated display. Don't worry about that. But the bottom line, in terms of this primary endpoint, a visual analog scale for global assessment, there was no difference between either of these two comparisons. There was an additional analysis done looking at the effect on renal function, and this is the snapshot of those findings. This was the bolus versus continuous. This is the high dose versus the low dose. Again, no statistical significance, and the numbers are really pretty modest, although there was a trend here toward worsening kidney function in those patients treated with higher dose furosemide, a trend. One would expect that would be the case, right? Because it has to do with the rate at which we diurese our patients, and what's referred to as the plasma refill rate, which I'll come back to when we're talking about ultrafiltration. So it really, if you have a volume overloaded patient and you begin to see kidney impairment, don't think necessarily I'm injuring the kidney or I've diurese the patients, I'm through. It really, if it has to do with anything, it has to do with the rate at which we're going, and what else is going on with the patient. So I think that's to be expected if you go quickly with higher dose furosemide. So now, what about ultrafiltration? And there has been, of course, ultrafiltration has been used for a long time, and more recently, as devices like this one have been generated that can demystify ultrafiltration a bit, make it simpler, put it in the dangerous hands of cardiologists and away from the protective hands of nephrologists. Bad things could happen, but also good things could happen, and there's been a hypothesis that ultrafiltration might be kinder on the kidney than diuretic therapy for a variety of different reasons, one of which might be that furosemide may have direct adverse effects on the kidney mediated through adenosine secreted by the juxtaglomerular apparatus in response to sodium delivery that may have direct adverse effects on renal hemodynamics. So there may be some direct effects of diuretics. So a variety of different reasons there's been an interest in going to ultrafiltration earlier as opposed to as a last resort. And the CARESS-HF trial was a study performed by the Heart Failure Network that looked at exactly this question, took patients with heart failure and worsening kidney function and randomized them either to continue on with aggressive medical therapy or to move to ultrafiltration. And this was the scheme of the investigation. And importantly, there was a somewhat prescribed direction for pharmacologic therapy, a stepwise approach with adding increasing diuretics, thiazide diuretics, then supporting it with other agents like inotropic or vasodilator agents, and then ultimately giving the option of switching over to ultrafiltration in a very stepwise progressive manner versus going directly to ultrafiltration. And I think that this is something to stare at exactly how this was done, because the result of the study actually favored forging ahead with pharmacologic therapy and not flipping over to ultrafiltration. And this is a complicated display, but it points out the complicated endpoint. It was a bivariate endpoint that included both loss of weight as a marker of fluid removal and increase in serum creatinine on the y-axis. And here's ultrafiltration and here's pharmacologic therapy. And the result was that pharmacologic therapy achieved the same degree of weight reduction, but with less worsening of kidney function, greater worsening of kidney function seen in the ultrafiltration group. This is an easier way to look at that. This is mean change in creatinine from baseline in the two groups, ultrafiltration in red. If you look at the 96-hour time point, there clearly was worsening kidney function in the ultrafiltration group compared to the pharmacologic therapy group. So now this tells us, I think, that first off, I think it's worth staring at exactly what was the protocol used by the CRESS investigators with pharmacologic therapy, but it does suggest that ultrafiltration ought to be left for a later resort, if you will. I don't think it means ultrafiltration is dead. It means we shouldn't jump to it too quickly, I think, or certainly not believe that jumping to it early can preserve kidney function. In fact, perhaps just the opposite. I did mention this concept of the plasma refill rate, and I think it's important, at least conceptually, to think about that or think about ways we can actually measure it, both with diuretic therapy and with ultrafiltration, which was not used in this study, but has been suggested to be used. And through measuring plasma hemoglobin concentrations, you can look at changes from hour to hour in plasma volume and estimate the plasma refill rate and look for the changes in plasma volume that suggest that you've hit upon a point in fluid removal where the removal from the intravascular space is equivalent to the refill rate in which fluid is being mobilized from the periphery. That's sort of the sweet spot that, at least conceptually, we have to aim for. We don't have to spend much time on this slide. This slide just plots plasma volume over time under this experimental condition with ultrafiltration, and then estimates plasma refill rate, from those changes. But conceptually, that I think is what we ought to be aiming for, a rate in which we're kind of matching the rate at which fluid is being mobilized from the periphery back into the intravascular space. Now, the Heart Failure Network is also exploring nasiritide therapy versus low-dose dopamine, and I'll show you quickly the background for that. Nasiritide, I think you guys know, has been very controversial with the suggestion of worsening kidney function, although that was not supported in the more recent ASCEND heart failure trial, which, by the way, also didn't clarify a therapeutic benefit from nasiritide. I hate when that happens. But anyway, I'll show you this study with low-dose dopamine, which has been criticized, but it is, I think it does suggest a role of low-dose dopamine. It's low-dose dopamine plus furosemide compared to high-dose furosemide, and this panel shows urine volume, suggesting that the low-dose low-dose dopamine plus furosemide group had, if anything, greater reduction in volume, greater fluid removal, greater urine output, slightly greater than the high-dose furosemide, and did so at less cost in terms of worsening serum creatinine. So this is the rise in serum creatinine with high-dose furosemide, not so much with the combination with low-dose dopamine, suggesting a potential role of low-dose dopamine. And I'll just mention that the ongoing ROSE trial, which you and we are participating in, is looking exactly at randomizing patients either to low-dose dopamine, nasiritide, or placebo in patients with heart failure and worsening kidney function, looking at these endpoints. And maybe this will help to clarify the role of these agents in that setting. Last two types of drugs that I'll touch on is vasopressin receptor antagonists, and then the newer agent Relaxin, which was just published and presented this past November. So we've been working on vasopressin receptor antagonists now for over a decade. We think it's we've thought of it as perhaps the last hurrah of neurohormonal antagonism, because vasopressin is upregulated in patients with heart failure, and we have drugs that impact on the vasopressin receptor, including this agent, tolvaptan, which is a selective inhibitor of the V2 receptor, which is the one that is responsible for free water retention. This is work by John Burnett, looking at a small group of patients randomized to either furosemide or tolvaptan, suggesting that at about equivalent degrees of fluid removal, unlike furosemide, tolvaptan tends to relatively improve renal hemodynamics compared to furosemide, which tends to worsen hemodynamics in this setting. So suggesting that the concomitant use of tolvaptan may in fact achieve the same degree of fluid removal with relative protection of kidney function. And then we published the Everest trial a few years back that was a large-scale 4,000 patient randomized controlled trial of tolvaptan 30 milligrams a day versus placebo, instituted in patients admitted with acute decompensated heart failure, low ejection fraction, and evidence of volume overload, and then continued for both inpatient and outpatient for a median follow-up of over 9 months. And this is the one-day result, and showed in these two twin trials, if you will, embedded within the larger trial, a significant reduction in fluid volume in patients randomized to tolvaptan, about 0.8 average kilogram reduction in body weight for tolvaptan compared to placebo. And that was associated with a statistically significant, although modest, relative improvement in dyspnea scores in the tolvaptan-treated group versus placebo-treated group. I still believe these are worthwhile findings. They're modest as they will, but it's a tough field to investigate. However, we were unable to show any impact in terms of long-term outcome. Now, the good news is we didn't kill people. Now, that seems like a modest goal, But of course, we can't quite say the same thing with dobutamine and milrinone. We're not sure that those drugs don't kill people. We're kind of sure tolvaptan doesn't kill too many people. At least when we look at all-cause mortality, the curves are exactly overlapping. So that's both, good news, and of course, we'd love to have seen it improved. We also did not see an improvement in mortality or heart failure hospitalization. I had hoped to see that because we were seeing a greater reduction in body fluid. However, I will point out, I'm not showing it to you because it's a post hoc analysis, but in patients with the lowest serum sodiums, we did see trends toward improvement in outcome. But I'm not going to show it to you because it was a small post hoc analysis. I will mention that it really had no adverse impact in serum creatinine, even though we did see a continued reduction in body weight over the course of the long-term follow-up. So I do think at the very least it can be a useful tool in select patients in terms of normalizing body weight where it's a struggle without much risk of worsening kidney function. So I will say that. We're still interested in this, and we and several other groups around the country are interested in pursuing the use of vasopressin receptor antagonists, which of course are approved for use in hyponatremia, but not specifically improved for the treatment of heart failure. But we're interested in doing this study called the Secret of CHF trial. I guess that's what it stands for. I have to tell you, my colleague Jim Udelson has wanted to name a trial the Secret of CHF for the last decade, and nobody's ever let him do it, so we finally let him do it. So here it is. It doesn't make any sense. But anyway, it's a cool name, maybe, I think. So anyway, we're looking at patients hospitalized with acute heart failure, but enriching the population by the fact they have to have one of these three things: either hyponatremia at baseline, renal insufficiency at baseline, or inadequate initial diuretic response by a definition that we've given to it arbitrarily. And if they have one of those, they can get in. And we believe that that will enrich the population in this small, I think, 230 patient study, I think, looking at looking specifically at dyspnea effects, but looking at a bunch of other things as well. We're still looking for sites for this study, by the way, and we'd love to have you in it if you're interested in that. I said I would mention the Relax data, and that's because this is hot off the press and very intriguing. So Relaxin, you may know, is an endogenous hormone that's in men and women, but secreted very heavily during pregnancy and mediates a lot of the hemodynamic changes associated with pregnancy. It's also been suggested to have a plurality of effects, including anti-inflammatory effects, anti-fibrotic effects. So it seems like a really cool hormone. And serelaxin is a recombinant form of this endogenous hormone relaxin. And so this is the result of this phase 3 randomized controlled trial called Relax-HF that John Teerlink both presented and published in November. And this is the positive finding that makes it a positive trial. The one of two primary endpoints that was only one of which was positive, the visual analog scale for dyspnea, which did show a fairly impressive looking, I guess, although I don't know how to interpret visual analog scales very well, but certainly a statistically significant effect on dyspnea over the 5 days. I'll point out that the co-primary of looking at dyspnea with a more conventional Likert scale trended in the right direction but did not reach statistical significance. But nevertheless, statistically, it was a positive trial based on this result. And there were a number of other cool findings. Now, it did not show a positive effect in terms of the pre-specified secondary endpoint of death or recurrent hospitalization over 60 days. But it did show a numerical improvement in mortality. Now, the investigators made, I think, a little bit more of this than I would. That's why I show the data this way as cardiovascular deaths at 60 days, which was pre-specified, and there's a trend here, but it's a nice directional trend and mirrors a similar trend that was seen in the phase 2 study. So maybe it's even real, but I would be a little bit careful about this. It's also coupled with a slight excess, numerical excess in hospitalizations, which worries me because usually these two things go together. You know, if you make the patient better, you keep them out of the hospital and you make them live longer. But certainly this is going in the right direction anyway and doesn't give us any concern, and it seemed to be a very safe drug, including, and that's why I stick it in this study, this talk about renal function, is that there were clearly fewer renal adverse events in the serelaxin group compared to the placebo group. So it's a very encouraging finding. I think you can look at this study glass half full or glass half empty. I think looking at it half full, this is the first study like ever of a drug in acute heart failure that hit its primary endpoint and has a lot of things that trend in the right direction, including kidney function and including mortality. Or you can look at it as half empty because in order to get into the study, you had to have a blood pressure of at least 125 millimeters of mercury. The drug is a vasodilator and resulted in about a 4 to 6 millimeter mercury reduction in blood pressure. And if you're a cup half empty person, you say, well, of course it's a vasodilator in a hypertensive heart failure population. I already use IV nitroglycerin or nitroprusside in those patients. Is this any better? But of course, these kinds of data aren't available with IV nitroglycerin and nitroprusside. So we could have some good discussion about whether we should jump to be using this drug or not, assuming that it is FDA approved, which it is not yet. Okay, so I'm going to sum up. I'll mention again that it's not all about the heart. It's about a bunch of different organs. We focused on the kidney today, and here are my conclusions. Renal physiology significantly impacts the pathobiology of acute heart failure. Abnormal and worsening renal function are adverse prognostic markers. Complex mechanisms contribute to renal impairment and acute heart failure, including reduced cardiac output and renal hypoperfusion, but importantly, elevation in central venous pressure and renal venous congestion, as well as neurohormonal activation. Volume correction impacts renal function in complex ways. Pharmacologic approaches to renal impairment have promise, but have not yet yielded a clear benefit. And finally, renal injury and dysfunction remain important treatment targets. So as I've shown you, there's a lot of interest in this. There have been some trials. There's a lot of other trials that I think are going to be directed toward the mechanisms of the kidney-heart interactions. And I hope that if you invite me back sometime in the years to come, or maybe if you come to our place and tell us about what's going on in this field, we'll find together that, in fact, some of these mechanistic concepts have borne fruit in terms of improving our therapy in patients with acute and chronic heart failure. Thanks very much for having me.
Thanks, Marv, for a fantastic talk. That was really very elegant. We're going to open it up for questions now. Just remind everybody to use your microphone so everyone can hear you everywhere. And do we have anybody who's figured out how to turn it on yet? Stan.
I think this is working, yes. You mentioned modest decrease in renal function, the modest increase in creatinine when we start to get worried about ACEs and ARBs, in terms of our therapies. Is it how fast it gets up, how fast that creatinine goes up? Is it a certain number that you're using in studies and everything in terms of where to say we really can't use ACEs and ARBs in this particular patient?
Yeah, I don't have any, that's a great question. I don't have any magical answer to it. I mean, the one study I can quote is that there was an analysis that looked at different levels of serum creatinine elevation and its impact on subsequent outcomes. And in terms of sensitivity and specificity for predicting badness, once you got up to, on average, more than a 0.3 milligrams per deciliter increase in serum creatinine, that was a better predictor of adverse outcomes. I'm not sure that really answers the question. And I guess, I don't have one. I mean, I guess I come back to saying that when, if that's what's driving the creatinine increase, chances are, it's a renal hemodynamic effect. If the patient's still making urine, it's probably not, unless they happen to have bilateral renal artery stenosis, it's not going to be a renal injury effect. So, I don't have any clear answer, and I get nervous too watching it go up. But
Microphone there. Just people remotely remind you can use that text box to send in a question if you want.
Considering the fact that a few patients with extraordinarily high venous pressure, say with constrictive pericarditis, develop nephrotic syndrome, do you think the high venous pressure adds to protein loss for lots of people and a reduction in oncotic pressure, and how that may interact with the results?
Well, that's a great question. I don't know. I do think, it's interesting because a low serum albumin is an independent predictor of adverse outcome in heart failure as well. I think you guys published something to that effect. I think, in fact, Jab had published something to that effect. I think also conversely, if you, I don't know how well that's been studied, probably not. I will say, though, that when I ask my nephrology friends, I've asked them, give me ways that I can tell whether if somebody has renal impairment, whether it's solely due to the heart or whether there's a concomitant primary kidney disease going on. And one of their answers is that if you see protein in the urine, it's probably primary kidney disease. And that they don't see that much of that, except for very, very modest elevations in urinary albumin in heart failure in the absence of primary kidney disease. Now, it's hard because how do you know, that the patient doesn't have concomitant kidney disease? But I think that's the best answer that I can give you, that I'm not aware that there's any clear, demonstrable impact of prolonged levels of central venous pressure on protein-losing states, but there could be at least a modest effect underlying that. I don't know.
Do we need to consider how to avoid admitting patients to the hospital who we're seeing who are quite symptomatic, very volume overloaded, and just trying to go slower with their therapy on an outpatient basis, IV diuretic a couple of times a week, that sort of thing? I think the data you show that as far as our goals, we try to get somebody in, get a lot of fluid out, get them out, and do we need to consider taking a different approach with some of these patients?
To be a little bit more patient in the hospital, in other words?
Patient in the hospital or in the outpatient setting, have mechanisms in which, a diuretic-resistant patient could be treated sort of episodically in the outpatient setting.
Yeah, I think all of the above. I think, we've got to move, to a medical model and a reimbursement model that doesn't, drive us too heavily to reduce length of stay, which is what we're in now. But frankly, I'm not buying the 30-day readmission metric either, because I don't think that's the be-all and end-all, because there are people building heart failure disease management programs that last 30 days and then fall off the cliff because nobody cares about what happens to patients after 30 days. And conversely, there may be patients that have to be readmitted. And by the way, that metric doesn't take mortality into account. So if a patient dies, you're good, okay, on that metric, and you're not readmitting them. Amazing. But I think all the points that you made are legitimate. I think I think the changing medical model that we're going to probably see in the next few years is going to help drive us clinicians to find what's best for the patient. What's best for the patient is going to be having the best, long-term outcomes associated with the greatest cost effectiveness. And I think left to our own devices and put into a model that does it, I think we'll find that happy medium. I'm a big believer that if a patient is volume overloaded and they have evidence of right heart failure, usually associated with low cardiac output and some renal impairment, the treatment goal is to get them euvolemic. That's the treatment goal. And, I personally had patients who came into the hospital looking like gigantic garbanzo beans and practically rolled into the hospital. And I've taken, and have been bounced around hospital to hospital with a few days of diuretics and shot out again. Or when their serum creatinine goes out by 0.1, the diuresis stops. And you keep them in and you patiently find a way to get them actually euvolemic. And their central venous pressure goes down, their tricuspid regurgitation goes down. You come into their room and suddenly they're up and around, walking around, "Doc, I feel better today." After about a week or more of diuresis, and you've hit that magic point where everything starts to get better. If you can find that spot, they can stay better for a long time, I think.
Last quick one.
So, to the point that Paul Walter made, there's certain things, when you say a patient has heart failure, it always bothers me to say that that's a diagnosis, because it's really not a diagnosis, and the coding people have us separating out acute systolic heart failure from diastolic heart failure, and all that bothers me a little bit from the categorization standpoint. But you got to make sure in every one of these patients in these studies that they don't have a few things that will just totally defeat you. That is mitral regurgitation, aortic stenosis, tricuspid regurgitation, and as Paul said, constrictive pericarditis. So when you look at, for example, an echocardiogram in someone with these syndromes, and the vena cava is very large and the hepatic veins are very dilated, then you know very well that when you start diuresing them that you can only go so far. So you need to make sure you eliminate all those things before you put them in the category, okay, let's put them in the hospital and give them some IV diuretic, and give it rapidly or give it slowly, plus or minus dobutamine, and see what happens. So every time you walk in the room, you've got a screen to say, well, let's see one of these mechanical things are present in order to kind of make the patient go forward.
Boy, I agree with absolutely everything you just said, and could not have said it as well. I'll take it a step further by saying that, we're even within the context, even if you eliminate all those things, we're still lumping people together that might be very different, and including whether they have ischemic heart disease or there's an active ischemic component. Is that what's the impact of functional valvular regurgitation, even if they don't have kind of a repairable lesion. So I agree with everything you said, and particularly the thing about that systolic, diastolic, acute, and chronic stuff. And I will just end by saying that just about every patient I admit to the hospital has acute and chronic systolic and diastolic heart failure. So I'll just share that with you. Thanks very much.
Thanks so much.
The preceding program is copyrighted by Emory University.